time. And we'll have for company Dr. Abhay Vasavada, Dr. Ramamurthy, Dr. Samresh, and myself. So, starting with the course itself, uh, the moment we move on, go out and move to the trade, we'll see a plethora of new instruments. And every company comes up telling that this is their instrument which will solve all the problems, this measurement is the most accurate, and so on and so forth. So I think with so many newer investigative modalities, cataract surgery has now become as important, pre-operative planning has become as important as the surgery itself. This used to be the paradigm for LASIK or refractive surgery, that is pre-operative diagnostics. But now I think time has come that even cataract surgery diagnostics have become extremely important. So are these newer investigative diagnostic technologies just hype or just marketing, or is there any additional help that we get? That is an addition. Is it just an additional? Is it an additional need or just additional cost? Before we actually move on to measuring these patients or using these diagnostics, these are the first couple of slides is I think what defines this entire course. And this is something that all of us need to now pay more and more attention for. That is to have a dedicated pre-operative time slot. You don't want to be in a rush in your clinic when there are already 10, 15 patients waiting outside. You are always under pressure to move on fast and quickly. And we may not be doing the adequate justice to that eye and to that patient. So it's extremely important to have a dedicated pre-operative time slot. And of course, a dedicated team for that. For example, at our clinic for the past more than 5 to 7 years, whenever a patient opts for cataract surgery, we tell them to hold on and come back on a separate day, which is when the pre-operative clinic is the time when only 5 or 7 of those patients posted for surgery the next or a few days later would be coming. So you have a specialized team, a specialized slot. And I think all of us now need to give more and more importance to this and create a pre-operative clinic. This is also extremely crucial. Although the patient may have a unilateral cataract, we need to keep in mind a plan for both eye surgery in the long run for the patient. Therefore, do a comprehensive examination of both eyes together so that a symmetrical plan can be made for both eyes. This may sound silly, more like residency training, but this is something that at least I find very useful to have a fixed written pro forma. That is, these are the 10 things, 11 things, 15 things, etc., whatever you may be doing. These are the things that I need to do in this patient before I actually sit, look at the readings and talk to the patient. So having a written pro forma also helps significantly. And now since we have decided the patient has come for this pre-operative clinic, how do we go about using all of these and many, many more fancy gadgets that many of us have? I think it starts with the very basics, that is to look at the ocular surface. And the ocular surface, as more and more all of us are realizing, is the cause for the most dissatisfied or the most unhappy 6/6 post-operative patient. And simple tests like a tear film breakup time or a Schirmer's test will give a clue towards the ocular surface condition of the patient. Also look at the lid margin carefully, because a lot of these meibomian gland dysfunctions may not be bothering him now, but the moment you operate, the moment you put him on so many post-operative antibiotics, steroids, preservative drops, this will ginger up the ocular surface and make the patient more uncomfortable. But these are many of these are subjective findings. More and more, we want objective documentation of what the status of the ocular surface is. And this is something that we have found quite useful in certain select situations. This is a test to measure the osmolarity of the tear film. And all of us know that more osmolar, the higher the value, thicker the tear film, or lesser the value, very thin the tear film, both of which are not good. So this is this comes with a chip card, and there are nomograms or values, but any tear film osmolarity more than 308 is a slight red flag. So at least, although even if you may not be able to do anything about it, either you can pre-treat these patients with ocular stabilizing medications or forewarn these patients that you are likely to have foreign body sensation until the drops are going on for another month or two or so, so on and so forth. So this is something that we find useful. Now coming to the measurement of the actual IOL power, I think optical biometry has changed the way we calculate IOL powers in a dramatic way. And now, at least from the podium, I would be very confident in saying that contact A scan should be abandoned completely. The next best to optical biometry would be immersion, and there are cases where even if you have access to optical biometry, because of the type of cataract, the optical biometry may not be able to give you a good reading. Now the optical biometry the newer optical biometers have the advantage not just of getting a good axial length reading, but they also give very good keratometry readings, which are important also for planning toric IOLs. With further improvements in optical biometers, with the newer generation swept source biometers coming up, notably right now the IOL Master 700 from Zeiss and the one from Tomy OA200, there is a higher penetration even in dense cataracts and in posterior subcapsular cataracts, reducing even further the need for immersion A scan. So we are moving further and improving the way we are measuring axial length as well as keratometry with the newer optical biometers. I'm sorry. Coming to the next investigative diagnostics, that is aberrometry. Now aberrometry until very recently was being considered only and only for hi-fi refractive surgeons when they are talking about flaps, quality of vision, etc., so on and so forth. But having incorporated it and having used it, we find it very useful even for our cataract patients. To simplify what this is an eye trace, ray tracing aberrometry, where the Placido, there is a Placido-based topography measuring the corneal aberration and the ray tracing aberrometry which measures the total eye aberrations, both of which, once you subtract both of them, you get what is the internal aberrations, which are most likely to be from the lens. They can be anywhere from the corneal endothelium onto the retina, most often from the crystalline lens. And that's how the topography data is also captured from the Placido ring based. Also, you get information about the pupil size of the patient. So you get, if the patient has a larger pupil, you may want to choose a particular kind of IOL. If the mesopic pupil of the patient doesn't go beyond 2 millimeters, any form of aspheric or multifocal IOL may not work for this case. So you also get not only the aberrometry data, but also the pupil size. And these are some case scenarios how aberrometry helps us not only in planning, but also in counseling. So this was a patient planned for cataract surgery and a good diopter, 1.2 diopters of astigmatism, and in our enthusiasm we suggested a toric IOL. But the patient shot back and told us that you have just come from a new fresh fellowship and you have this new posters put up in your OPD, and now I've never worn a cylindrical glasses in my entire life, and after 60 years you tell me I have astigmatism which will need this more expensive lens. So this is where aberrometry helped us to convince this patient to use this as a diagnostic tool. I'm sorry, unfortunately, I'm not able to bring up the mouse here. Yeah. So this is the internal aberrations of the patient, and this is the corneal aberration. So if you notice, the corneal astigmatism here is right now being completely neutralized by the internal astigmatism. That is the natural lens of the eye, the cataractous lens. Now the moment you remove this and replace this with a simple monofocal lens, this entire corneal astigmatism is going to get manifest, leaving behind a post-operative residual cylinder. And therefore, we discussed this with the patient and explained to him using this graph, and fortunately agreed for the toric IOL. And this is the post-operative part of the same patient where the entire corneal astigmatism is almost completely neutralized by the internal toric IOL astigmatism. Now coming to these fancy terms of angle alpha and angle kappa, if you notice here that the aberrometry or any eye has 3 points. That is, first the center of the limbus, the center of the pupil, and the visual axis. Now the patient is the rays of light are going to pass through the center of the visual axis, whereas the IOL is actually going to sit in the center of the capsular bag. So if the angle alpha, that is the angle between the center, of the visual axis and the center of the limbus is quite off, then what will happen is that although you may do a perfect surgery, well-centered IOL, what you feel in the bag, post-operatively what is going to happen is, with this large angle alpha, the patient's visual axis is actually going to pass through, if you notice here, through these multifocal rings. This is going to lead not much of a refractive surprise, but this is going to increase the photic or mesopic phenomenon that the patients are going to have post-operatively. So therefore, more chances of glare and halos. And for now, there is no golden cutoff line, but most experts believe that anywhere around 0.4 to 0.5 angle alpha should be considered as a red flag or a cutoff for multifocal IOLs. If there is one investigative technology which I think has revolutionized not only retinal surgeons but even all general ophthalmologists, I think that is the optical coherence tomography, or the OCT. And so often we come across these absolutely healthy looking normal retinas having a distorted foveal contour because of epiretinal membranes. And therefore we decided to conduct a study to find out how many patients who are undergoing actual cataract surgery have macular pathology, which a retinal surgeon has put up in his notes to be a normal retina and a normal fundus. What we found in our results, the good part is that in 95% of the eyes, we could capture an OCT. So the OCT is able to capture even in very significantly dense cataracts. So it has a good penetration. In what I said, normal, in those diagnosed with a normal fundus by a retinal surgeon, beware, OCT examination revealed ERM in 7% eyes, RP irregularity in 4%, and foveal attenuation vitreomacular traction in about 3%. So all of these patients were missed out not just by the general ophthalmologist, but even by the retinal surgeon on 78 and 90D clinical examination. And this is a classical example of a normal looking fundus showing a vitreomacular traction or an early lamellar macular hole in the post-operative period. And coming to finally the corneal investigations, they may not be required in all situations, but particularly in abnormal or special situations like this, where you are considering toric IOLs, where the readings are showing, may or may not be showing great astigmatism, you need to look at the regularity of the astigmatism. And more importance is now being given to the posterior corneal curvature, not just as far as detecting pathology goes, but also as far as IOL power calculation goes. And there are devices now or instruments which measure the posterior corneal curvature, like the Pentacam. If you see here, this is the topography map, this is the pachymetry map, this is the anterior elevation and the posterior elevation. And you may be able to pick up cases like this with high posterior corneal astigmatism or elevation, which may be suggestive of a form-fruste keratoconus. And these are the patients where you want to avoid a particular kind of a premium IOL. So I think newer diagnostics, of course, not everything that comes new is good or useful. There have been, instruments which we have bought and we have found after 6 months they are of no use to us. But I think we need to have a positive mindset and keep moving forward. And newer diagnostics, I think, are going to help us to raise the bar as far as expectation managements are concerned, as far as creating more and more happy patients are concerned, and in creating more predictable and precise outcomes. So thank you very much. I would now invite Dr. Abhay Vasavda to talk about customized IOL solutions for each patient. Yes, we can have questions after every talk, if there are any. Okay.
While we are waiting, I want to recognize two individuals in the hall, past President Dr. N.S.D. Raju and the President Amulya Sahu of the manual small incision cataract surgery, which is promoted all over the world. So thank you, sir, for attending. And those who are still doing this wonderful technique of small incision, manual technique, everything we say is relevant 100%. You can do exactly the same detailed preoperative evaluation. Consider what kind of IOL will put, when will you put, and so on. So just stay tuned with us, and you will be okay. We all receive research grant support at our center from Alcon, but has no relevance to this topic, except that you will hear or see RESTORE written, which is a synonym of traditional multifocal lens.